Let's go over the warm-up. First question, to which lymph nodes does each of the following regions drain? The upper rectum drains to the perirectal nodes and then ultimately to the inferior mesenteric nodes. The lower rectum drains to the internal iliac nodes. The external anus below the pectinate line drains to the superficial inguinal nodes. And the testes drain to the para-aortic nodes. Next, what's the function of McConkey's auger? So McConkey's auger is used to select out gram-positive bacteria so that only gram-negatives will grow, and it also distinguishes lactose fermenters from non-lactose fermenters. McConkey's auger contains crystal violet and bile salts which inhibit the growth of gram-positives, and it contains lactose as the only carbohydrate plus a stain called neutral red. So if these organisms ferment lactose, they're going to take up the neutral red, which means that the lactose fermenters form pink colonies on McConkey's auger, and the non-lactose fermenters will form white colonies. And the last question, what portion of the eye is opacified in a cataract? It's the lens of the eye. Now let's get started with the lecture.
Oh, you're back for more liver lectures. For me, you must be a glutton for punishment. Better check your liver ultrasound for fatty liver disease. The lecture is on liver pathology. Let's start by talking about liver studies. On your test, you'll be given a bunch of lab functions related to the liver, and you'll be asked to interpret the most likely cause of liver function test abnormality. Now, we've done some introductory information on this when we talked about liver anatomy and physiology and alcoholic hepatitis, but now let's get into more depth about other liver inflammatory diseases. All right, so the most basic aspect is that cell markers are indicators of cell damage. When a hepatocyte is damaged and the cell bursts open, the contents of that cell spill into the serum, so part of our liver function tests indicate the degree to which liver cells are being damaged. The aminotransferases are what most people think of when we say LFTs. They include aspartate aminotransferase, also known as AST, and alanine aminotransferase, also known as ALT. Now, importantly, AST is not specific to the liver, and it's also present in the skeletal muscles. So one confounder of AST levels is rhabdomyolysis or muscular dystrophy or muscular crush injuries. ALT is more specific to the liver. We can gain some information about the possible pathology by comparing the AST to ALT ratio. AST is found more in the mitochondria of liver cells, and so it's more prone to being spilled with mitochondrial toxins like alcohol. And a commonly thought of ratio is that AST 2 times greater than ALT is an indicator of acute alcoholic liver damage. ALT is more concentrated in the cellular cytoplasm, so if ALT is greater or at least equal to AST, a viral hepatitis is more likely. The next biomarker we see is gamma-glutamyl transpeptidase, also known as GGT. GGT is also elevated with excessive alcohol consumption. So if you have an AST to ALT ratio of 2 or greater and a normal GGT, chances are that you're being pointed away from alcoholic liver damage towards some other pathology. GGT can also be elevated with diseases affecting the biliary tract. The next biomarker is alkaline phosphatase. Keep in mind that alkaline phosphatase is also found in the bone, so it can be confounded by osseous injuries and high bone turnover diseases like Paget's disease, or even constitutionally elevated in children who are growing. With relation to the liver, alkaline phosphatase is similar to GGT in that it's associated with the biliary obstruction. Biliary obstruction is most commonly due to gallstones, but it can also be caused by cancer or some autoimmune pathologies. We're going to talk about that in a future lecture. All right, now let's take a look at this cut surface of a liver. It looks like the liver is sprinkled with nutmeg, which is why we call it nutmeg liver. So what is nutmeg liver? Well, you can imagine that we're seeing enlarged hepatic venules and peripheral hemosiderin staining in the darker nutmeg speckled areas. Nutmeg liver occurs when there is hepatic congestion. This is commonly caused by right-sided heart failure. Importantly, no matter the cause, if congestion of the liver persists for a long period of time, you can get what's known as central lobular necrosis and fibrosis. If this goes on long enough, you end up getting cirrhosis. And since this is often due to heart failure, we call it cardiac cirrhosis. Now, another cause of hepatic congestion is a disease known as Budd-Chiari syndrome. This is occlusion, usually due to thrombosis, of either the inferior vena cava or the hepatic outflow vein. Now, this may seem simple, but let me just remind you that there are two venous systems of the liver. Okay, we've got the hepatic portal vein, which is the confluence of the portal venous system, which brings blood to the liver from the gastric tract. And then we have the hepatic vein, which is the main outflow vein of the liver to the IVC. Budd-Chiari syndrome, like right-sided heart failure, which also backs up blood in the IVC, starts with central lobular congestion and necrosis and can also result in congestive liver disease and fibrosis. Now, the clinical manifestation of Budd-Chiari includes the typical signs of portal hypertension. Though the blockage is of the hepatic vein or the IVC, the backup of blood ends up resulting in portal congestion and hypertension. So we see hepatomegaly, ascites, abdominal pain, and we can also see esophageal varices, caput medusae, and internal hemorrhoids. We can differentiate between hepatomegaly due to right heart failure versus due to Budd-Chiari by looking for jugular venous distension. If you have congestion of the liver with jugular venous distension, then that's because of right-sided heart failure. But if you have congestion of the liver with no jugular venous distension, then it's probably not because of right-sided heart failure, but something else like Budd-Chiari syndrome. Budd-Chiari is associated with hypercoagulable states, pregnancy, polycythemia, and hepatocellular carcinoma, all of which increase the risk of thrombosis of the hepatic vein. Overall, though, it's pretty rare. It's about 1 case per million people. All right, let's look at another pathology, Reye syndrome. Reye syndrome is a potentially fatal disease, and the buzzword association for this is aspirin in children with respiratory viral illnesses. So, although this can occur rarely in people without aspirin and has even been seen in some adults receiving aspirin with some flavivirus encephalitides like West Nile and dengue, the most common thing you're going to be asked about is aspirin in children. Now, the pathophysiology of Reye's disease is currently unknown, but the main term I want you to remember for Reye syndrome is hepatoencephalopathy, meaning you get pathology of the liver and the brain. Early in the course, patients will have rash, vomiting, headaches, confusion. This then progresses to hypoglycemia, stupor, coma, and death. And if you did a liver biopsy on these patients, you would see fatty liver damage. Some of the encephalopathy that we see is secondary to the disease process itself, but some of it's contributed to by the hyperammonemia, which is also known as hepatic encephalopathy, that occurs with fulminant liver failure. Reye syndrome is thought to be caused from damage to cellular mitochondria, although the pathophysiology, as I said before, is unknown. The aspirin metabolites are thought to decrease beta oxidation by reversible inhibition of mitochondrial enzymes. And again, aspirin is not recommended for children for this specific reason. One notable exception, and one that you should potentially know for step 1, is that you should use aspirin in children with Kawasaki's disease. So remember, Kawasaki's disease is characterized by high fever for 5 or more days, strawberry tongue, conjunctivitis that spares the limbus, palmar erythema, and spotty rash over the face and trunk. These patients should get aspirin. All right, on to Wilson's disease. Wilson's disease is an autosomal recessive disease in which you have inadequate copper excretion into the bile. So the bile is the main mechanism by which we excrete copper. And if you can't get copper into the bile, then you're going to have copper accumulation in the liver and then in multiple other places in the body. In Wilson's disease, there's a defect in a specific enzyme called ATP7B. And that enzyme is responsible for secreting copper into the bile, and it's also important in transporting copper in the serum by adding it to a protein called ceruloplasmin. In general, patients with Wilson's disease have a low serum level of ceruloplasmin, and that can be one of your diagnostic criteria. But again, the main problem is that you're not getting rid of copper. You can't get copper into the bile and then out of your body, which leads to copper accumulation. And that's particularly in the liver, the brain, and the cornea. Another name for Wilson's disease is actually hepatolenticular degeneration, because you get cirrhosis of the liver and damage to the lenticular nucleus of the brain, which consists of the putamen and the globus pallidus nucleus, don't forget that, and these are the places that are typically affected. You also get these corneal deposits known as Kaiser-Fleischer rings. These are golden brown corneal rings around the edge of the eye, and these are indicative of copper deposition. You can also see renal dysfunction in patients with Wilson's disease, specifically Fanconi syndrome. Now remember, Fanconi syndrome is where you have proximal tubular dysfunction in the kidney. Proximal tubule is the first place where you have renal absorption of solutes. So if you have dysfunction in that part of your nephron, the proximal tubule, then you're going to be spilling out all the vital things into your urine. All right, so how do we treat Wilson's disease? Penicillamine, that's the drug to remember. Penicillamine chelates copper and allows for excretion through the urine instead of into the bile. This is pretty easy to remember because it's a copper disorder, and pennies are made of copper, sort of, and you treat this copper disorder with penicillamine. So that's Wilson's disease. All right, on to another metal accumulation disorder, hemochromatosis. This is a disorder of iron hemostasis. So the classic triad in hemochromatosis is cirrhosis, diabetes mellitus, and skin pigmentation. And because of the combination of skin pigmentation and blood sugar derangement, you often hear the term bronze diabetes used in association with this disorder. You also see dilated congestive heart failure with electrocardiographic abnormalities including arrhythmias, and then you'll also see testicular atrophy and impotence in males, and again, like in Wilson's disease, there's an increased risk of hepatocellular carcinoma with the cirrhosis. So there's two major causes of hemochromatosis. The most common cause is an autosomal recessive mutation in the HFE gene, which has effects on the production of a protein known as hepcidin. Now, hepcidin is the major iron uptake protein regulator. Decreased hepcidin from HFE mutation results in increased iron uptake. Hemochromatosis can also be secondary to excessive transfusions. Patients with beta thalassemia or sickle cell disease have chronic anemia that often requires multiple transfusions over a long period of time. So while the red blood cells are being destroyed and then being replenished by transfusion, we are building up huge amounts of iron from the destruction of those red blood cells. So you may be given iron labs and be asked to interpret them. The primary components of iron labs are iron, ferritin, transferrin, and transferrin saturation. So the iron value is indicative of unbound iron. Ferritin is a complex of iron and apoferritin and is the primary intracellular iron storage protein. Transferrin is a protein that allows for transfer of iron in the blood. Total iron binding capacity is how much free transferrin there is. Transferrin saturation is related to how much of the transferrin is bound to iron. So when we look at the iron panel for a patient with hemochromatosis, we see that they're in a state of iron overload. So you'll see increased total iron, decreased total iron binding capacity, and increased transferrin saturation. Ferritin levels are also usually high. All right, so how best to treat hemochromatosis? Well, we can use phlebotomy to discard the iron in the red blood cells. If you take out red blood cells on a regular basis over time, you're going to start losing iron. Now, you can imagine that some of the conditions that would lead to secondary hemochromatosis, the ones that are transfusion dependent, like beta thalassemia and sickle cell anemia, you can't really do phlebotomy with them. So in these patients, we use a chelating agent like deferoxamine. That's the basics of hemochromatosis. All right, so the next liver pathology we're going to talk about is alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency is an autosomal codominant disease, and it involves two major organ systems, the liver and the lungs. So trypsin, as you might remember, is a proteolytic enzyme produced by the pancreas. Now, alpha-1 antitrypsin is a protein that generally inhibits most proteolytic enzymes that are released from inflammatory cells as a normal part of bodily defense against microbes. Elastase is a particular proteolytic enzyme that is usually inhibited by alpha-1 antitrypsin. Lack of the inhibition of elastase in the lungs results in pan-acinar emphysema. The liver pathology is a little bit more complex. We see the mutant form of alpha-1 antitrypsin polymerizing in the liver cells and becoming toxic. Clinically in alpha-1 antitrypsin, you see early onset, which means younger than 50, pan-acinar emphysema and liver cirrhosis, which might manifest as jaundice and elevated LFTs. The typical situation is a patient who is too young for liver and lung pathology or who doesn't abuse their organs enough to manifest the pathology. All right, let's talk about hepatic adenomas. These are liver tumors that are going to occur most often in females aged 20 to 44, but even then, it's pretty rare. They're associated with combined oral contraceptive use, anabolic steroid use, and also with glycogen storage diseases types 1 and 3. Now, some of these patients have right upper quadrant pain, but it's mainly an asymptomatic disorder, and many times this is just an incidental finding on imaging. Malignant transformation to hepatocellular carcinoma takes place in about 10% of patients. So while the hepatic adenoma in and of itself isn't a big deal, if it becomes hepatocellular carcinoma, that's a big problem. If a patient on an oral contraceptive develops a hepatic adenoma, we typically stop the oral contraceptive and then check serial imaging and alpha-fetoproteins to make sure they're not developing hepatocellular carcinoma. All right, short one, hepatic angiosarcoma. It's a blood vessel tumor in the liver. This is a malignant endothelial neoplasm that occurs in the liver. Risk factors for this are vinyl chloride and arsenic exposure. That's all you need to know for step 1 for this particular disease. The last topic today is hepatocellular carcinoma. This is the most common primary malignant tumor in the liver of adults. There are several pathologies that increase the risk of hepatocellular carcinoma. In general, anything that causes cirrhosis increases the risk of hepatocellular carcinoma over time. So, the chronic hepatidities, Wilson's disease, hemochromatosis, alpha-1 antitrypsin deficiency, and alcoholic cirrhosis, those are the most obvious ones. A particular carcinogen buzzword to remember is aflatoxin from Aspergillus fungus in peanut farmers. Now, the symptoms of hepatocellular carcinoma include jaundice, tender hepatomegaly and ascites, and hypoglycemia. You can also see polycythemia that results from elevations of erythropoietin. Now, you can imagine that a malignancy of the liver is likely to cause venous stasis in the liver and is an inherently prothrombotic state, so we need to worry about Budd-Chiari syndrome as well. All patients with cirrhosis or chronic hepatidities need to have monitoring of alpha-fetoprotein and interval ultrasounds to assess for the development of hepatocellular carcinoma. Okay, let's go on and do the end of session quiz. What is Budd-Chiari syndrome and what conditions are associated with it? Budd-Chiari is occlusion of the IVC or the hepatic veins. It's usually associated with polycythemia vera, pregnancy, hepatocellular carcinoma, or any generally prothrombotic state. Next question. A young man presents with ataxia and tremors. He has brown pigmentation in a ring around the periphery of his corneas. What treatment should he receive? This guy has Wilson's disease, so he should receive penicillamine. What is the underlying problem in Wilson's disease? You'll remember that the underlying problem in Wilson's disease is impaired copper excretion into the bile. Ceruloplasmin, the copper ferrying protein, is usually low, and copper isn't put into the bile for elimination. What are the characteristics of Wilson's disease? Remember that there is copper accumulation resulting in basal ganglia degeneration, resulting in a Parkinsonian-type symptoms, asterixis, cirrhosis, those brown Kaiser-Fleischer rings around the edges of the cornea, personality changes, and dementia. Next question. What is the classic triad of symptoms in hemochromatosis? Remember here, bronze diabetes. So that's diabetes, bronzing of the skin, and cirrhosis. What lab tests are used to diagnose hemochromatosis? We use iron studies. Ferritin is your screening test, and that will be elevated, but you'll also see an elevated transferrin saturation, elevated serum iron, and decreased total iron binding capacity. What is the treatment for hemochromatosis? Phlebotomy primarily, and sometimes deferoxamine. What are the risk factors for the development of hepatocellular carcinoma? Remember, chronic hepatidities, including hepatitis B and C, hemochromatosis, alpha-1 antitrypsin deficiency, hepatic adenomas, and in general, anything that causes cirrhosis. All right, now on to our rapid fire facts. Hepatomegaly, abdominal pain, ascites, Budd-Chiari syndrome. Green-yellow corneal deposits, Wilson's disease. Those are also known as Kaiser-Fleischer rings. Low ceruloplasmin, that's Wilson's disease. Cirrhosis, diabetes, and hyperpigmentation, think of hemochromatosis. All right, that's all for this lecture. See you next time.